Okay, good. Let us now have another discussion in today's class, and this is the continuation classes about oncology and specifically on oncology. These are the type of conditions, type of diseases, cancer, which are associated with blood. And our today's topic is about acute lymphoblastic leukemia, which is coming up to be a very common problem in our setup, which is causing a lot of admission in our patients and causing a lot of burden in terms of health in our setup. Let us look. The leukemia are the most common malignant neoplasm in childhood, and they account for about 1% of all malignancies that occur in less than 15 years of age. In early years of life, there is about, in America, less than 15 years, 3,250 children are diagnosed with a cancer of the blood, which is called leukemia. And the annual incidence is around 4.5 cases per 10,000 cases. So that's the epidemiology. So in all acute lymphoid leukemia account for around 77% cases of all children with leukemia. You can see that acute lymphoid leukemia is very common, accounting for more than 75%, more than 3/4 of all these so it's a very big problem. So then we have acute myeloid leukemia, which is count for 11%, and then chronic myeloid leukemia for around 2 to 3%, and then juvenile myeloid leukemia account for 1 to 2%. So the remaining cases consist of a variety of acute and chronic leukemias that do not fit in any class definition for acute lymphoid leukemia or acute myeloid leukemia or chronic myeloid leukemia or juvenile myeloid leukemia. So let us look at acute lymphoblastic leukemia, of which you have seen that it accounts for 70%, 75% of all cases of childhood cancers. So acute lymphoid leukemia is account for more than 75% of all acute leukemias. So let us look at its look like. So all children with the acute lymphoid leukemia was first disseminated as a cancer soon to be curable, and consequently has represented the model of malignancy for the principal cancer of diagnosis, prognosis, and treatment. It actually is a heterogeneous group of malignancies with a number of distinctive genetic abnormalities that result in variety clinical behaviors and response to therapy. So the clinical behavior of acute lymphoid leukemia does not have a very specific clinical behavior. The symptoms can vary depending with the one person, one client, the other. And also the response to therapeutic or treatment also depends with various factors. So all acute lymphoid leukemia is diagnosed in approximately 2,400 children less than 15 years of age in America each year, with a peak incidence at 2 to 3 years of age and occurs more in boys than in boys at all ages. So chromosomal abnormalities of acute lymphoid leukemia is that the disease is more common in children with certain chromosomal abnormalities. It's very common in children who have Down syndrome, who have Brody syndrome, or ataxia, telangiectasis, or function anemia. In identical twins, the risk is more than 70% if acute lymphoid leukemia is diagnosed in the first twin during the first year of life, and the twins share the same monoclonal placenta. That means if they are in the same placenta, then the chances of developing acute lymphoid leukemia to the other twin is around 70%. So if the first twin develops acute lymphoid leukemia by the age of 5 to 7 years of age, the risk of the second is at least twice than in the general population, regardless of the zygosity of these type of twins. So the etiology of acute lymphoid leukemia is not well understood, though several factors genetically and environmental factors are associated with childhood leukemia. For example, exposure to medical diagnostic radiation, both in utero and also in childhood, has been associated with an increased number of incidences of acute leukemia. So, not just factors other than radiation have been identified in America. So, in certain developing countries, there has been an association between B-cell acute leukemia and external virus viral infections. So let us look at a cellular classification of this acute lymphoid leukemia. So the classification depends on a characteristic of malignant cells in the bone marrow to determine the morphology, phenotype characteristics, and measured by cell membranes markers, and is also cytogenic and molecular and genetic features. So the morphological role usually is likely to establish diagnosis, and the other studies are essential for diagnosis for the disease classification, which can have a major influence on the prognosis and the choice of appropriate therapy. So the most important distinguishing morphological features is the French, American, British, which is a recognized classification of acute lymphoid leukemia. It is called French, American, British L3 subtype, which is evidence of mature B cells leukemia. So the L3 type, also known as bucket leukemia, is one of the most rapidly growing cancer in human and requires different therapeutic approach than any type of subtype of acute lymphoid leukemia. So let us look at the French, American, British classification of lymphoblastic leukemia. And you see that it is classified into 3 classifications depending on various characteristics. For example, you can look at the cell size. In the first classification, the small cells are dominant, and in 2, it is large cell heterogeneous in size, and also 3 is larger homogeneous. So in nuclear chromatin, you'll see that in lymphoid 1 is L1 is homogeneous in any one case, and in L2 is variable heterogeneous in one case, and finally stage 3 is finally stripped and homogeneous. Then you have to look at the nuclear shape of this type of leukemia. You see that there is no visible or small in inconspicuous, more variable vascular, and also in 2 is irregular, cleft find, and indentation common. And then in 3 is regular, oval, or round. Then you check on the nucleoid, it is regular, occasionally clefting and indenting. That is in type 1, and type 3, stage 2, is that one or more percent of often large nucleoid, and the stage 3 is prominent one or more of a nucleoid. So amount of cytoplasm is scanty in 1, and also variable, often moderately abundant in 2, and moderately abundant in 3. So basophils of cytoplasm in is slightly or moderately increased in 1, and also variable deep in 2, and very deep in 3. Then we have cytoplasmic vascularization available in 1, and also variable in 2, and often prominent in 3. So that is the French, American, British classification of lymphoblastic leukemia, which checks on various type of characteristics depending on the size and the amount in it. That is, they check on the cell size, they check on the chromatin nuclear, they check on the nuclear size and nucleate, amount of cytoplasm, and basophilia of cytoplasm, and cytoplasmic vascular lesion. So you can see that that is how the morphological appearance of acute lymphoid leukemia cells classified according to the French, American, British system. And you can see that you can see that A is in terms of morphological, that is how it is. There's more than 2, they are slightly, and then 3, they are scattered. That is how it looks like. So you can see that L there shows a large type of inside the cell type of lymphoid. So you can see the cells how they look like. So let us look at phenotypic surface marked so that about 85% of cases of all acute lymphoid leukemia are derived from progenitor of B cells. About 15 are derived from T cells, and about 1% are derived from the B cells. So you can see that B cells progenitor plays a big role in terms of acute lymphoid leukemia. So a small percentage of children with leukemia have a disease characterized by surface markers, both lymphoid and myeloid and relatives. So let us see a common chromosomal abnormalities in the acute lymphoid leukemias of children. You see that precursor acute lymphoid blastic leukemia, the precursor B, precursor BT, or 1221, all those ones. Down ones, you can see that the one which are very common, you see that the favorable one is precursor B, trisomy abnormalities 4, 10, and 17 are most favorable with 25% incidences, then followed by precursor B, T1221, favorable in 20 to 25%. Then you can see that precursor B with diploid is favorable with 20 to 25%, and then the others are not have a lot of concern in terms of incidences. So those are the three ones which have a lot of incidences in terms of chromosomal abnormalities, type of origin in terms of these type of acute lymphoid leukemia. Remember that acute lymphoid leukemia, there is also a player in terms of environmental factors like radiation or other drugs. So we cannot purely say that it is chromosomal in some cases. So that's our area of discussion. There is no proper study which has been shown that the essence about the environmental factors in acute lymphoid leukemia. This one is more of associated with chromosomal, which are genetically or inborn type of factors. So in acute myelogenous leukemia, you see that T821 is very favorable with 5 to 15%, followed by M4, which is having a favorable 2 to 11%, with developing INVO 16. Other ones are not very significant except M3, which has T17, T5 is favorable 5 to 6%. So in this case that you can see that B precursor cells plays a big role in the case of acute lymphoid leukemia. Again, despite even you can see the bucket type of virus related is B cells is again minimum with 1 to 2%. So let us, the polymerase chain reaction and the fluorescence in situ hybridization techniques often ability to pinpoint molecular genetic and it takes more number of malignant cells during follow-up and they are proven clinical treat. So that is the type of PCR type of method which is used to diagnose cases and for further follow-up in terms of management. So let us look at the clinical manifestation of acute lymphoid leukemia. So the initial presentation of acute lymphoid leukemia is usually non-specific and relatively brief, and patient come with not very vague, we call them vague symptoms in the hospital. And most of these fixes are like things like anorexia, fatigue, malaise, irritable, and also present just as intermittent or low-grade fever, bone or less often joint pain, particularly in the lower extremities, and may be present. Patients often have a history of an upper respiratory tract infection preceding the second and the third month. So this type of patient in tropics, patients are always treated too much about malaria by the time they are diagnosed with this problem of acute lymphoid leukemia. With this acute lymphoid leukemia. So let us see, look at clinical and laboratory features of diagnosis of children with acute lymphoblastic leukemia. You see that the symptoms and physical findings, percentage of the children have high fever of 61, and you know that fever, children in MCI fever is topics in our setup: fever in children is associated with either malaria. The fever is associated with the measles. As per the guidelines of MCI, children under 5 years, fever is either malaria, fever is either measles. In our setup, is more of malaria. So at the end of the day, currently even the geographical epidemiological axes are changed, where that you are appreciating so many viral infections. So these children will have got a lot of treatment about either empirical management of malaria or empirical management of viral infections, or even sometimes management of even bacterial infections as like tonsillitis, pneumonia, or all those type of cases. By the time you diagnose these cases of acute lymphoid anemia. So in this case, leukemia. So in this case, these children requires the person, the primary physician should be able to have high index of suspicion to start looking what is causing this type of problem. So then these children will have potassium hemorrhage, papula, then they have bone pain, lymphadenopathy, splenomegaly, hepatosplenomegaly. So all these cases, like from bleeding, bone marrow, lymphadenopathy, splenomegaly, hepatosplenomegaly, this patient coming in a primary health setup in Kenya will be most likely diagnosed with either tropical malaria, like tropical hepatosplenomegaly. Then the treatment will be out of the box. So there are probably features is like the patient is having a leukocyte counts of less than 10,000. Most of them are 53%, others have 10 to 49, others have more than 50, 17. So HB is always around less than 7, and most of them, and the platelet count is less than 20. Most of them, you know that the normal platelet is 150 to 300. Then the lymphoblast morphology is obvious. This one is done, is a very special test, which is done using a flow cytometry machine. At our setup, it's a little bit difficult to do these ones, but most of these ones have lymphoblastic morphology of L184, and you remember the L1, how it looks like in the classification of French American classification of acute lymphoid leukemia. So less commonly, the symptoms may be of severe malnutrition, can take time, may be localized predominantly to the bones or joint, and can include joint swelling. Bone pain is severe and can wake the patient at night. So as the disease progresses, signs and symptoms of bone marrow failure become more obvious, with the occurrence of pale, fatigue, exercise intolerance, wheezing, or ecstasis, as well as fever, which may be caused by infection of the diseases. So an infiltration can cause lymphadenopathy, hepatosplenomegaly, and testicular enlargement, or CNS and involvement, the cranial nerve neuropathies, headache, seizures. Sometimes they can have respiratory distress due to severe anemia, or sometimes mediastinal node compression of the airways. And the most common is the thymus related type of lymph node. So in this case, when you do your physical examinations, your findings will see the patient is filled with restlessness and petrific and petechial hemorrhage on the skin and mucous membrane hemorrhage, and can affect bone marrow failure. The proliferative nature of the disease may be manifested by lymphadenopathy and splenomegaly, and less commonly hepatosplenomegaly. So hepatomegaly. So spleen enlarges faster than liver, and the lymphadenopathy comes earlier in this type of what? Patient. So in patient with bone marrow or joint pain, there are many, there may be excretive tenderness and over the bone or objective involvement of joint swelling and effusion. So with bone marrow involvement, deep bone pain may present, but tenderness will not be elicited. So rarely patients show signs of increased intracranial pressure that indicate leukemia involvement of central nervous system. So this one is not very common in patients unless the heart. So these include like papular edema, lateral hemorrhage, and also cranial nerve passing. So the mediastinomasis can cause respiratory distress, usually related to anemia, can also occur in patients with the obstructive airways problem, which can result to losing due to larger arterial mediastinomasis in the thymus or nose. So this problem is mostly atypically seen in adolescents, boys with T cells, acute lymphoid leukemia. So the T lymphocyte related acute lymphoid stain in boys is more related with the mediastinomasis. And you remember that our discussion is that B precursor cells is the most common associated with this type of acute lymphoid leukemia. So T cells, acute lymphoid leukemia, also known as a higher leukocyte count. So the precursor of B cells, which is CD410 plus or common acute lymphoblastic leukemia antigen CAR positive, is the most common types of conditions. So immunotype with onset of 1 years of age. So the mediastinal leukocyte count at presentation is 33,000, although 75% of the patient have count of less than 20,000. Thrombocytopenia is seen in 75 patients, and hepatosplenomegaly is seen in 34 patient of this. So in all types of leukemia, central nervous system are rarely seen at presentation, averaging around 5% on a patient with around 5-10% have a blast in the CSF, T lymphoblast in the CSF. And testicular involvement is rarely evident at the diagnosis, but prior studies have indicated an occurred involvement of 35% of the boys. So there is no indication for testicular biopsy. So let us see on how do we diagnose these cases of acute lymphoid leukemia. So the diagnosis of acute lymphoid leukemia is strongly suggested by peripheral blood findings that indicate bone marrow failure. So anemia and thrombocytopenia are seen in most patients, and also leukemia cells may not be reported in the peripheral blood in routine laboratory examination. So sometimes in routine laboratory tests, you cannot see those ones, so you have to do peripheral blood film by a pathologist. So that is so many patients with acute lymphoid leukemia present with leukocyte count of less than 10%, and in such cases, the leukemia cells often are rare lymphocyte with a typical lymphocyte, and it is only on further evaluation that the cells are found to be particularly of malignant clone. So when the result of an analysis of a peripheral blood film suggests the possibility of leukemia, the bone marrow should be examined promptly to establish the diagnosis. So it is important that all studies necessary to confirm a diagnosis and adequately classification the type of leukemia be performed, inclusive bone marrow aspiration, biopsy, flow cytometry machine, and cytogenetic and molecular studies. So all acute lymphoid leukemia is diagnosed by a bone marrow evaluation that demonstrates more than 25% of the bone marrow cells as a homogeneous population of the lymphoblast. So staging of acute lymphoid leukemia is based on partly on a cerebrospinal fluid examination. If lymphoblasts are found on the CSF, leukocyte is relevant and overt CNS or meningeal leukemia is present. These findings reflect a worst stage and indicate the need for additional CNS and systematic therapies when you see leukocytes elevated in CSF fluid, specifically the lymphoblast. So definition of central nervous system disease tests and diagnosis based on cerebrospinal fluid findings. So to know that whether these patients are started manifesting with CNS classifications of these diseases, that no lymphocyte in the CSF is SN1, SN2 is white blood cells with definable blast on centrifuge examinations, and more than 5 white blood cells with the blood cells for cranionephropathy. That is the classification of the acute lymphoid leukemia in complications of CNS. Now, the staging lumbar puncture may be performed in conjunction with the first dose of intrathecal chemotherapy if the diagnosis of leukemia has been previously established from a bone marrow evaluation. So the initial lumbar puncture should be performed by an experienced proceduralist because of trauma. Lumbar puncture is associated with an increased risk of CNS relapse. So let us look at the differential diagnosis of acute lymphoid leukemia. So the diagnosis of leukemia is readily made in the patient with atypical signs and symptoms, anemia, thrombocytopenia, and elevated white blood count with blood present on the smear. So elevation of the lactate dehydrogenase is often accrue to the diagnosis of acute lymphoid leukemia. So when only pancytopenia is present, aplastic anemia or congenital acquired and myelofibrosis should be considered. Failure of a single cell line as seen in transient erythroblastopenia or childhood immune thrombocytopenia, and congenital or acquired neutropenia sometimes produce a clinical picture that is difficult to distinguish from acute lymphoid leukemia that can require bone marrow examination. A higher index of suspicion is required to differentiate all from infectious mononucleosis in patients with acute onset of fever and lymphadenopathy, and from rheumatoid arthritis in patients with fever, bone marrow pain, but often no tenderness and joint swelling. These presentations also can require bone marrow examination. So, acute lymphoid leukemia must be differentiated from acute myelogenous leukemia and other malignancies disease that invade the bone marrow and can have clinical laboratory findings similar to acute lymphoid leukemia, including neuroblastomas, rhabdomyosarcomas, and Ewing sarcomas and retinoblastomas. So the differential diagnosis in children acute lymphoblastic leukemias can have non-malignant conditions such as juvenile rheumatoid arthritis, infectious mononucleosis, idiopathic thrombocytopenia, papilla, allopertussis, parapertussis, or aplastic anemia, acute infectious lymphocytosis, and the malignant cases which can be have a differentials like neuroblastoma, retinoblastoma, and rhabdomyosarcoma, unusual presentation like hypereosinophilic syndrome. So let us look at the treatment of acute lymphoid leukemia. So there is the single most important prognostic factor is the treatment. Without effective therapy, the disease is fatal. And the survival rate of children with acute lymphoid leukemia since 1970s have improved as a result of clinical trials have improved the therapies, and the outcome survival is also related to age and phenotypes. So the choice of treatment of acute lymphoid leukemia is based on the establishment clinical risk relapse in the patient with various screening among the subtype of all acute lymphoid leukemia. So three of the most important predictive factors are the age of the patient, the time of diagnosis, the initial leukocyte count, and the spread of response of the disease to treatment. So let us look factors associated with prognosis for patients with acute lymphoblastic leukemia. What are the factors which determines the outcome? The factor which determine the outcome is like the initial white cells count, the sex, the rapid of the leukemia cytoin reduction, the cytogenicity, the French, American, British morphology, mediastinal masses, organomegaly, and lymphadenopathy, hemoglobin level, please, platelet count, serum immunoglobulin, myelin antigen expression, and leukemia cells, nutrition status, and also immunological subtype. So different studies groups use various factors to define risk, but age between 1 and 10 years and a leukocyte count of less than 50,000 are widely used to define a very average risk. A child who are more than 10 years of age or who have an unusual leukocyte count of more than 50 are considered to be at high risk. Now, uniform age and white blood cells count of criteria for B precursor acute lymphocytic leukemia standard and high-risk cohort at the Cancer Treatment and Evaluation Program Cancer Institute workshop. You can see the risk factors, the standard, the white blood cells definition. White blood cells count less than 50,000 microliters. The survival rate 4 years is 80%, 4 years, and percentage for B precursor is 68%. Then I is the white blood cells more than 50,000 or age more than 10 years, 63.9%, a percentage for the B precursor patient is 32%. So, so the outcome for patients at high risk can be improved by administration of more intensive therapy despite the greater toxicity of the therapeutic disease. So, infant with acute lymphoid leukemia, along with patients who present with specific chromosomal abnormalities as T922, T411, have a very high risk of relapse despite intensive therapy. So the treatment is based on the principles of supportive care induction and post-induction cases. So supportive care is close attention to the medical supportive care needs to the patient, especially in successful administering aggressive chemotherapeutics programs. Patients with high white blood count are especially prone to tumor lysis syndrome as therapy is initiated. So chemotherapy often produces via myelosuppression, which can require erythrocyte and platelet transfusion. Always require high index of suspicion and aggressive empirical antimicrobial therapy for sepsis in febrile children with neutropenia. So patients must receive prophylactic treatment for pneumocystic juvenescent pneumonia during chemotherapy and for several months after completing treatment. And the treatment here uses either sulfur drug acceptance in this case because the immune is suppressed. Number of now this one is you want to see the suspending the presentation of the result of therapy in a patient with leukemia. This one was adopted from Russia. So you can see that the disease clinically determinable one malignant cells. Then the progression, you can see the diagnosis of the leukemia started. The disease was detected. Then on the 10th week, that is the time the disease was diagnosed. And the only time you can be able to detect is when the number of leukocytes is more than 10,000. 12,000 at the time you start detecting this disease. Then the therapy is determined, and then you can see now it comes down, and then they can see the relapse after the stopping of the treatment in the 16th week. So let us see therapy for standard risk in patients with acute lymphoid leukemia is use the induction for first month, use post-induction, then in post-induction you consider consolidation for 1 month, interim maintenance therapy, and then re-intensification for 2 months, and then maintenance in girls for 20 months, and in boys for 32 months. So the induction type of management in this case is that the initial therapy is designated to eradicate the leukemia cells from the bone marrow, and this is called remission induction. During this piece, the therapy usually is given for 4 weeks and consists of increasing weekly and corticosteroid such as dexamethasone or prednisone and either repeated doses of native asparaginase or a single dose of a long-acting pegylated asparaginase preparation. So intrathecal cytarabine and or methotrexate also may be given. Patients at higher risk also receive the medicine at weekly intervals. 98% of in remission as defined by the less than 5% blast in the bone marrow and return of neutrophils and platelet counts to the near normal levels after 4 to 5 weeks of treatment. So the classification of bone marrow remission status in acute lymphoid leukemia. So M1 bone marrow, if the blast is less than 5%, bone marrow less than 25%, 2, and bone marrow less than more than 25% is 3. That is the classification. Bone marrow remission status in acute lymphoid leukemia classification. So the CNS prophylaxis is the second piece of treatment, focuses on CNS therapy. in an effort to prevent late CNS relapse, and intrathecal chemotherapy is given repeatedly by lumbar puncture in conjunction with intensive systemic therapy. The likelihood of late CNS relapse is thereby reduced to 5%. So a small percentage of patients with the features that predict high risk of CNS relapse may receive eradication to the brain. So you do radiations to the brain, and you remember that radiation is an environmental factor which also can cause acute lymphoid leukemia. So this induces patients who at the same time diagnosis have lymphoblasts in the CNF and either elevated CSF leukocyte count or physical signs of CNS leukemia, such as cranial and palsy. So in post-induction, after remission has been induced in conjunction with the CNS therapy, many regimes provide 14 to 20 weeks of multigenic therapy in the drugs and send used variety depending on the risk group of the patient. This period of treatment is termed as consolidation and intensification. It's called and intensification. So many patients benefit from administration of a really intensive phase of treatment, approximately 5 to 7 months after the beginning of the therapy and after relatively non-toxic phase of treatment, interim maintenance to allow recovery from the prior intensive therapy. So maintenance is finally patients are given daily mercaptopurine and weekly methotrexate, usually with the intermittent doses of vincristine and corticosteroids. This period, known as the maintenance phase, often lasts 2 to 3 years, depending on the protocol used. In the future, treatment also may be stratified by the gene expression profile of leukemic cells or the presence of minimal residual disease. In particular, gene expression areas induced by exposure to the chemotherapeutic agent can predict which patients have drug-resistant acute recurrent leukemia. So, pharmacogenetics testing of the diaphrine S-methyltransferase gene, which converts mercaptopurine or diaglipin, both pro-flags into active chemotherapeutics agent, can identify rapid metabolizers associated with toxicity or slow metabolizers associated with treatment failure, thus optimizing drug dosing. So treatment of relapse, the major impediment to a successful outcome is relapse of the disease, and the relapse occurs in the bone marrow in 15 to 20 and carries the most serious implications, especially if it occurs during or shortly after completion of the therapy. So intensive chemotherapy with a gene agent not previously used in the patient followed by allogeneic stem cells transplantation can result in a long-term survival for patients with bone marrow relapse. So CNS relapse. The incidence of CNS relapse has decreased to less than 10% since introduction of preventive CNS therapy. And I think you have covered that and you have seen how it happens. So CNS relapse may be discovered at the time of routine lumbar puncture in asymptomatic patient. Symptomatic patients with relapse in the CNS usually present with signs and symptoms of increased intracranial pressure and can present with isolated cranial nerve palsy. Diagnosis is confirmed by demonstrating the presence of leukemia cells in the CSF. So the treatment includes intrathecal medication and cranial or cranial-spinal irrigations. Systemic chemotherapy also must be used because these patients are at risk for subsequent bone marrow relapse. Most patients with leukemic relapse confined the CNS do well, especially those with whom the CNS relapse occur longer than 18 months after initiating of the chemotherapy. So let us look at testicular relapse. The testicular relapse occurs in 2% of boys with acute lymphoid leukemia, usually after completion of the therapy. A chance relapse occurs as painless swelling or both testes or one. The diagnosis is confirmed by biopsy of the affected testes. Treatment includes systemic chemotherapy and possibly local irradiation. High proportion of boys with testicular relapse can be successful in treatment and the survival rate is good. So a small number of patients with particular poor prognosis features, such as those with T9 translocation known as the pyrimidine chromosome or extreme hypodiploidy may undergo bone marrow transplantation during the first remission. Prognosis. Most children with acute lymphoid leukemia can be expected to have a longer time survival with the survival rate of more than 80% at 5 years from diagnosis. So most important prognostic factor is the choice of appropriate risk-directed therapy with the type of treatment chosen according to the subtype of acute lymphoid leukemia and the initial white blood cells count, the age of the patient, and the rate of response to the initial therapy. So the hard and fast prognostic factors of acute lymphoid leukemia is age less than 1 year, more than 10 years at diagnosis, leukocyte counts of more than 50,000 per liter at diagnosis, and T cells immunophenotype and the slow response to initial therapy, hypodiploid and the prepending chromosomes and myeloid leukemia, lymphocyte leukemia gene rearrangement and the addition of the I, Ks, and Fms genes are the adverse prognostic factors which influence the outcome of this disease. More factors favorable to characteristic are rapid response to therapy, hyperdiploid and disomy of specific chromosomes and the rearrangement of the telomere gene in the chromosomes. So, minimal residual disease. Patient in clinical remission can have minimal residual disease that can only be detected with the specific molecular proofs to translocation and other DNA markers containing leukemia cells or specialized flow cytometry. So, myeloid remission disease can be quantitative and can provide estimate of the burden of leukemia cells present in the bone marrow. High level of bone marrow present at the end of the induction suggests a poor prognosis and high risk of subsequent relapse. Myeloid relapse of 0.01 to 0.1% on the marrow on day 20 of induction is a significant risk factor for short-term event-free survival. Now, prognosis factors in childhood acute lymphoblastic leukemia is the favorable factors is we have the factors like if the child is 1 to 9 years, it's a very good. More than 5 to 10 years is intermediate, and favorable is less than 1 year. And if the patient is having acute myeloid leukemia, a core with myeloid lymphatic leukemia. So with a white blood cells counts of less than 50, favorable, more than 50, intermittent, and immunotype precursor B cells hyperdiploid of more than 50 chromosomes with a DNA index of 1 to 1.6 with trimsines of 4 to 10 and 17. These ones are favorable. Then CNS status stage 1, that is less 5 blast cells, and myeloid remission disease less than 0.01%. And the factor to each prognosis determines the outcome of this disease in children. And this one brings us to the end of this topic about acute lymphoid leukemia.